This presentation is going to give you some tips about 99214. And they're going to be things that I just notice are missing a lot of times when I audit medical records. Now, it's not an all-inclusive list of all E&M codings. It's just targeting on this one level of service. And I'm going to give you some tips that would help you support that code when you're billing E&M services. Now, the very first thing that I have to stress is the number one problem that I'm seeing with notes is physicians are just literally doing chief complaint, follow-up meds, no complaints. 6-month follow-up, no complaints. You have to ensure under the new guidelines that the chief complaint or HPI indicate the reason for the encounter. And it should technically match up with the assessment and plan. So if you just say 6-month follow-up, no complaints, and your assessment and plan has 25 different diagnoses, I'm not going to be able to count those under the new rules because you didn't establish medical necessity up front. Now, unlike the old days, you don't have to write 4 HPI, the status of 3 chronic conditions. You could simply say, patients here today to follow up on hypertension, diabetes, sleep apnea, chronic kidney disease, etc. You can do that. Your medical assistant can do it. I don't care. It just has to be done. It has to be clear. The only time that your chief complaint wouldn't match up with your assessment and plan is if during the review of systems or the physical exam, you uncovered something that the patient didn't initially complain about, a lump in the breast, tachycardia, a heart murmur, something like that. And we're going to find that information in the physical exam or the review of systems. Another thing is that when you get to the bottom of that note and you're matching up your history and exam to your assessment and plan, each assessment should really have its own plan. So, hypertension, continue lisinoprol, 100 milligrams, diabetes, Farxiga, I'm sorry, I can't say that word, never have been able to say that word. I'll just say Ozempic, metformin, continue that. Depression, continue follow up with psychiatry and continue bupropion, bipolar, continue Depakote, chronic kidney disease, indicate the stage, because the stage of the chronic kidney disease, if it's an association with hypertension or diabetes, we can code that differently. We can code hypertension with chronic kidney disease or diabetes with chronic kidney disease, as well as the diabetes. But don't put everything under one diagnosis. Don't say hypertension, continue lisinoprol, continue metformin, continue Depakote, continue bupropion, Ozempic. Don't put it, separate it. Take the time to separate it. CMS has increased the work RVUs on these codes, and they expect you to have a history of exam that matches your assessment and plan. And it's just that simple. And sometimes when I'm auditing your notes, if I don't see a good chief complaint HPI, I just say the code is totally not supported. And that's exactly what would happen to you on post-payment review. When it comes to your assessment and plan, and we look at the medical decision-making, it's also critical that you understand the new guidelines, and you have to understand the definition of chronic. Chronic are conditions that are expected to last at least a year or until the death of the patient. Now, some systemic diseases we know, hypertension, diabetes, osteoarthritis, chronic kidney disease, these are going to be lifelong systemic diseases. But other problems aren't so obvious. So it's important for you to indicate the word chronic at goal or chronic not at goal. And you could do chronic stable, chronic not at goal. But the reason that I suggest at goal and not at goal is because that's what's in the criteria. Because you might have a patient whose blood pressure is 180 over 100, and you change them or start them on new medication. Well, they come back a week later and have their blood pressure checked, and now it's 150 over 80. Well, it's improving, but it's still not at goal. So that's still considered a chronic illness that is or acutely worsening. So a chronic condition that's not at goal, even if it's diabetes, if you just see a patient for diabetes and it's not at goal, you can meet this criteria for the number of presenting problems, which is just one of the criteria out of 3. You got to meet 2 out of the 3. The first one is this presenting problems, but it's important for you to indicate at goal, not at goal, next to every diagnosis. And if it's a diagnosis like anxiety that doesn't necessarily last a year, or if it's GERD, which you may not necessarily last a year, or it may be some kind of pain, radiculopathy, lumbar pain, cervical pain. We don't know unless you tell us that it's chronic. And I would go as far to say, with my private clients, to state in the assessment and plan, cervicalgia, chronic, expected to last at least 1 year or until the death of the patient with a quick text. And then you can put your assessment and plan and whether or not that problem is at goal or not at goal. Sorry, not my rules, but that's how you're going to get audited. And I'll tell you right now, in the state of Georgia, where I live, Anthem is downcoding a lot of 214s before they even look at them. So if I have to try to fill out an appeal letter and send it back to you, it's going to go to an auditor who's not your friend. And they're going to expect to see you following these very clear guidelines that are in the American Medical Association book that doctors write. There are no coders writing the AMA CPT book, and CMS has adopted these rules. So you can kind of get the idea that you have to be specific. With a 214, again, just to reiterate, chronic conditions are expected to last at least a year until the death of the patient. You should really concentrate on documenting that, whether a condition is at goal or not at goal, especially if it's not a systemic disease that we just know inherently is going to last that much time, like GERD, anxiety, pain. Can't stress it enough. It's the number one reason that I downcode doctors on these visits, and they get frustrated with me, but the average auditor has an associate's degree in criminal justice, accounting, or biology. It's an entry-level kind of position at a lot of insurance companies, and it takes them, they go through your notes. I look at, on average, 10 encounters an hour, and I'm quick because I've been doing this for 30 years, but it may take them, because they're nitpicky, they may look 4 or 5 hours at one note. So they're looking for all of these different elements. In the data section, it's also very important. Most primary care doctors can meet the category 1 criteria for level 4 visits, which is just a combination of any 3 of the following things. So if you review notes that are outside of your specialty, so external notes from each unique source, that could be a point. And what we're trying to do with the 1-4s is normally we're going to make it on presenting problems and risk, but the data is something that you guys often overlook and is not as important, but it really can be important. So you get a point for every external note that you might review, but you only get that point one time. So when I go to my internist, each visit, she looks at my nephrology notes. She gets a point for that if she documents that she reviewed Dr. Brazina's notes. She'll look at my psychiatry notes because I'm on some medication, and she'll say, I reviewed Dr. Lee's notes and it showed this. She also orders a lot of tests. Now, if you order a test, you get a point for it, but you only get that point one time. So when she orders my A1C, my CBC, my urine protein, my TSH, my vitamin, she only gets to count those labs individually one time. Now, when I come back in 6 months and she reviews those labs, she doesn't get to double dip. She doesn't get to count them again. The only time she gets to count a lab that she's reviewing is if it was from an outside source. So if she's reviewing notes or labs from a hospital, that's going to be bundled into the review of prior external notes. But if you're looking at an X-ray for a patient who has low back pain, that you didn't order, but you're just looking at the results of it, that would count as a point. If you have to get a history from somebody other than the patient, even if it's a child and you're getting the history from the parent, document that. If they're dementia or they have Parkinson's or another condition, they're senile, they can't answer your questions appropriately. You got the history from somebody other than the patient, make sure you document that. So you can see that in primary care, when you're treating people who have chronic diseases, it's very easy for you to get 3 points, even if you're just ordering a test. Now, this little asterisk means each unique test that has its own CPT code. The only time you can't count this is if you do X-rays in your office. X-rays have a professional and technical component, and the assumption is for Medicare, you're already getting paid for that X-ray, so they're not going to let you count that. But point of service lab tests that are results only, like CBCs, even if you do a CBC, a lipid, or an A1C in your office, you can count those because those don't have professional and technical components. They are result only tests, and you can count those. But just remember, don't get crazy. You can't double dip on labs. You only get to count them one time. The next little tip is on the complexity. We look at moderate complexity here, and patients who are on prescription drugs, it's important to indicate that you're refilling, starting, or stopping medications. If there is a patient who has a diagnosis or treatment that's significantly limited by social determinants of health, this is a new area this year that came out in 2021. And what it does is it allows you to identify via a diagnosis code patients who might not be able to control their blood pressure because right now inflation is, I guess, higher than it's been since the 80s. And sometimes people now are trying to decide whether or not they feed their family or get their medication. So it's very important that we look at these social determinants of health. And I'm going to show you what those are here next. If you have a phone out, you might just want to take a picture of these, but this is a list of a range of codes that you can use, and you can find them in your EMR or your ICD-10 book that reflect social problems that people have that will impact a diagnosis or treatment. So if they don't have good education or literacy, if they're unemployed, exposure risk factors, if people are homeless, people have low social insurance expectations, problems related to upbringing, not having adequate support at home, psychosocial circumstances, and other psychosocial circumstances. I would just take a moment. I mean, food deserts are on there, lack of adequate food, lack of good water. These are all conditions that might impact one's ability to treat their diagnosis. Now, I wouldn't expect you to say that Steve is a 53-year-old homeless veteran. These are the exception to the rule. You can put these in your assessment and plan without having necessarily mentioned them in your history or your physical exam. And they can still help count towards that moderate level of complexity. So one of the things that I try to really encourage physicians to do is, even though we looked at, and I'm going to slide back here, we looked at presenting problems, we looked at some common risk and data points here. You only need to fulfill the requirements of 2 out of those 3, but I say, listen, go all 3. If you have a couple chronic conditions that are at goal and you're ordering 3 blood tests and they're on prescription drugs with the social determinants of health on post-payment review, that is never going to be an issue. So you've got elements of each of the 3 categories. So what I like to say in my talks is that sprinkles on a donut. That just makes it extra good, because donuts inherently are really good, and sprinkles or icing on a donut makes them even better. So these are just some things to kind of think about when it comes to specifically you wanting to build a 214s. Is it chronic? Is it at goal? Is it not at goal? Itemize your blood test. Itemize whether or not you got history from somebody else. Let me know all the notes that you might have reviewed for that particular visit, because you only get to count those visits once. Am I reviewing outside labs, outside images? Because those would count, because you're not double dipping. You didn't order them and review them. And then finally, is the patient on prescription drugs? Do they have a social determinant of health? Those are things that would really help you support that level of service. If you have questions, feel free to give me a call. There's my number. I always encourage you, though, to first reach out to your own professional billing organization or your office coder. And then if you can't get anywhere with that, you can call me. This is my fax number. Send me an email, visit my website. If you send me an email, please indicate who you're with in the subject line, so I just don't delete it. I get hundreds of emails from people who I don't know, who just find my website. So if you say, hey, Steve, it's Dr. Baggett from Alice Hyde or New Hampshire Hospital System, I know who you are, and I will hook you up with an answer, okay? Thank you very much for your time, and I appreciate you listening, and have a great day.